Prasoon, thank you so much for that elaborate introduction. And again, I would like to welcome everyone in this platform that is in EDSIS. And it's truly has taken up to the level of a very international level, and we are all being able to connect every 2 weeks in this platform. And I'm proud to present today, and it's an honor. All right, so what I'm going to talk today is sarcopenia and frailty and implications for liver transplantation, as Prasoon just mentioned. And these are my disclosures. I'm principal investigator for several drug studies from our site. I'm on the advisory board of Indian Journal of Gastroenterology. I also serve on the editorial board of several journals, including as editor-in-chief of Translational Gastroenterology and Epidemiology. I've also received federal funding. So this is the outline of my presentation today. We'll start with some definition of sarcopenia and frailty, then I'll touch on pathophysiology, implication in patients with advanced liver disease and cirrhosis, liver transplant candidacy, post-transplant outcomes, and therapeutic interventions. So first, starting with the definition of sarcopenia and frailty. Frailty is a phenotypic representation of impaired muscle contractile function. And sarcopenia is the phenotypic representation of the loss of muscle mass. The term sarcopenia is derived from the Greek word sarx for flesh and penia for loss. The conceptual overlap between frailty, sarcopenia, and their contributing factors is what is highlighted in this diagram. Both conditions share several contributing factors, and they often coexist. And worsening patient outcomes. Starting with frailty, it refers to a decline in overall strength and resilience, making patients more vulnerable to stressors. On the other hand, sarcopenia, which refers specifically to the loss of muscle mass and strength, the two overlap significantly, particularly through factors like aging, muscle wasting, and inactivity. The key contributors to both frailty and sarcopenia include inadequate nutrition, specifically lack of calories and protein, along with recurrent hospitalizations, and socioeconomic challenges that can limit access to proper care. Frailty has unique drivers, such as hepatic encephalopathy, refractory ascites, endocrine dysfunctions, all of which are common in liver disease patients. Sarcopenia, on the other hand, is heavily influenced by inactivity and the direct effects of muscle wasting. Ultimately, the interaction between these factors create a vicious cycle. For example, comorbidities and repeated hospitalizations lead to further decline, making recovery more difficult for these patients. So to improve outcomes, it's critical that we address both frailty and sarcopenia in our treatment plans through interventions like better nutrition, physical rehabilitation, and managing underlying liver conditions. Here in this slide, we illustrate the multiple mechanisms that contribute to the sarcopenia in patients with cirrhosis. Sarcopenia, or the loss of muscle mass and function, is common in cirrhosis due to various complex metabolic and pathophysiological challenges, as we discussed in the earlier slide. First, we see how bacterial translocation from the gut leads to the release of inflammatory cytokines, contributing to muscle breakdown. And second, there are decreased dietary intake in cirrhosis due to a variety of reasons, ascites, anorexia, malnutrition. There are many factors that contribute to this and that led to dysfunctional, that lead to muscle breakdown. Then hepatic urea cycle, there is impaired hepatic urea cycle in cirrhosis, And as we all know, this leads to an increased ammonia levels. The rise in ammonia, it directly impairs the muscle function. And this rise in ammonia directly impairs muscle function through myostatin. It stimulates myostatin, and myostatin leads to muscle breakdown. And third, the glycogen stores. These are reduced in cirrhotic patients. The glycogen stores are reduced in cirrhotic patients, causing the body to enter a state of accelerated starvation, where both fat and muscles are catabolized for energy. If I can tell you, a cirrhotic individual, if he fasts, he loses as much of glycogen in 8 hours is equivalent to almost 4 days of a normal individual who fasts. So you deplete your reserve pretty fast in a cirrhotic patient, and then it leads to depletion or dependence on the fat depots as well as the muscle catabolism to meet your energy needs. Additionally, there is lower level of branch chain amino acids in cirrhotics, particularly leucine, and then also testosterone, and increased presence of myostatin, which is a muscle growth inhibitor, further that contributing to the muscle wasting. Finally, the imbalance between protein synthesis and muscle breakdown, that leads to a decreased muscle mass and contractile function, which is the hallmark of sarcopenia in these patients. Here in this slide, we have outlined the pathogenesis of sarcopenia, specifically the signaling pathway involved in muscle protein synthesis and degradation. Let's start with branch chain amino acid, or particularly leucine, which activates the AKT-PKB pathway, which activates this pathway. This pathway promotes muscle protein synthesis through mTOR activation, inhibits muscle breakdown by suppressing GSK3 beta and FOXO. So leucine plays a positive role in building and maintaining the muscle. However, cirrhosis introduces other factors like ammonia, which activates myostatin, as we just discussed a little earlier. So myostatin is a negative regulator of muscle mass, and it promotes muscle protein degradation. This creates an imbalance, tipping the scale towards muscle breakdown. So in summary, branch amino acids and leucine supports muscle growth through positive signaling, while ammonia and myostatin contributes to muscle degradation, which is a key factor in sarcopenia, especially in cirrhotic individuals. This slide explains the impact of advanced liver disease, such as cirrhosis, and on testosterone levels and the results in health consequences. Now, testosterone is a vital anabolic hormone that we all know that helps maintain body composition, muscle mass, and overall physical strength, which is critical for preventing frailty. In the body, testosterone circulates in three forms: free testosterone, which is about 1% to 4%, and albumin-bound, which is 55%, and the sex hormone-bound globulin, sex hormone binding globulin bound, about 45%. Total testosterone includes all three fractions, but the free testosterone is what directly influences target cells and induces androgenic effects. Cirrhosis often leads to hypogonadism and low testosterone levels, which is associated with a very poor health outcomes, including increased frailty, sarcopenia, and fat accumulation. So these factors ultimately contribute to high risk of morbidity, mortality, and more frequent hospital admissions. Interestingly, even in compensated cirrhosis, patients' total testosterone may appear normal due to elevated sex hormone binding globulin levels, making free testosterone more accurate marker for hormone function in these patients. So there is some evidence from limited clinical trials suggesting that testosterone supplementation in cirrhotic patients can help improve testosterone levels, which may enhance frailty outcomes and muscle mass without significant adverse effects. Again, these are based on limited studies, and I'll go through those in a little later. Now, this diagram illustrates the complex relationship between liver cirrhosis, sarcopenia, and the dysbiosis, or the imbalance of the gut bacteria. Now, in liver cirrhosis, multiple factors contribute muscle wasting and sarcopenia. These include portal hypertension, protein energy malnutrition, starvation, and increased inflammation. These changes lead to a hypermetabolic state and a decrease in branch chain amino acids and glycogen storage, all of which, as we discussed a little earlier, contribute towards muscle breakdown. One of the key mechanisms is hyperammonemia, which triggers muscle proteolysis and muscle breakdown by activating the UPP pathway, which is a ubiquitin proteasome pathway. This combined with hypermyostatinemia, elevated levels of myostatin, results in decreased muscle protein synthesis, directly contributing to the sarcopenia. On the right side, in addition to this, what we have highlighted here in this diagram is the role of dysbiosis in liver cirrhosis. Dysbiosis refers to an imbalance between the beneficial and the harmful gut bacteria. In cirrhosis, we observe there is a reduced bacterial diversity, increased intestinal permeability, and bacterial translocation. Increased levels of endotoxins and harmful byproducts due to small intestinal bacterial overgrowth. These factors contribute to exacerbation. These factors further exacerbate the liver cirrhosis complications and promote inflammation, ultimately accelerate muscle loss and progression to cirrhosis. So overall, in summary, this slide shows how liver cirrhosis, muscle breakdown, and gut dysbiosis are interconnected and with each influencing progression of the liver cirrhosis. Here in this diagram, we illustrate the impact of sarcopenia on survival in patients with cirrhosis. So on the left, we have two CT scans. We see CT scans comparing two cirrhotic patients, both with the same BMI, 32 kilogram. Here is 32 kilogram. Both of the same BMI, but very different skeletal muscle mass index, skeletal muscle indices at the L3 vertebra level. This is the standard where we measure the SMI or sarcopenia. So the top image shows patients with higher SMI of 70.8, indicating more muscle mass. And the bottom, the image shows the sarcopenia with a very low SMI level of 49. So even though both patients have the same BMI, the one with the lower muscle mass, which is sarcopenia, is at greater risk for poor outcomes. And this is illustrated on the right side of the diagram here. And what you see are Kaplan-Meier survival curves that show a clear difference between the two with and without sarcopenia. So this data emphasizes that sarcopenia, regardless of the BMI, is a critical predictor of survival in cirrhosis. Addressing muscle loss in these patients could potentially improve their outcomes. Here in this Kaplan-Meier curve, basically, we have illustrated or emphasized how sarcopenia is an independent risk factor for poor survival in cirrhotic patients, particularly in those with low MELD scores. The Kaplan-Meier survival curve here shows the survival rates of cirrhotic patients awaiting liver transplantation. Now, the patients are categorized by their MELD scores above and below 15, and by the presence or absence of sarcopenia. For patients with a MELD score less than 15, sarcopenia is a significant predictor of worse survival outcomes, as shown by the steep drop in the survival curve for the sarcopenic group. Patients with low MELD scores and without sarcopenia have notably better survival rates. In contrast, for those with a MELD score of 15 or higher, the effect of sarcopenia on survival is less pronounced but still evident. So the key takeaway is that sarcopenia can adversely affect survival even in patients with a less severe liver disease, as indicated by lower MELD scores. This highlights the importance of addressing muscle wasting in cirrhotic patients, especially those awaiting liver transplantation with a low MELD score. And this is specifically true in living donor liver transplantation. Now, I'm going to go to the next one here. So this slide presents a meta-analysis that is pulled from multiple studies to estimate the overall prevalence of sarcopenia in patients with cirrhosis. So on the right side, we see the results of 23 studies, each contributing data on sarcopenia prevalence in cirrhotic patients. Now, these studies report sarcopenia prevalence rates ranging from 15% to as high as almost 68.5%, depending on the cohort. At the bottom of the graph, we see the pooled overall prevalence of 37.5% with a 95% confidence interval of 32 to 42. This pooled estimate highlights the substantial proportion. Over a third of patients with cirrhosis suffer from sarcopenia, underscoring the significance of muscle loss in liver disease and the need for early recognition and intervention. Now, this graph actually shows the pooled prevalence of sarcopenia in cirrhotic patients and how it impacts their survival. On the left side, the bar chart shows the prevalence of sarcopenia across different patient groups. And the overall prevalence as 37.5%, meaning over a third of the cirrhotic patients are affected by sarcopenia. And sarcopenia is more common in males, which is almost 41.9%, than females, which is 28.7%. When comparing patients with the different causes of cirrhosis, those with alcoholic liver disease have the highest prevalence of 49.5%. 49.6% compared to 33.4% in those without alcoholic liver disease. So in terms of disease severity, sarcopenia is more prevalent in patients with more severe Child-Pugh score, Child C, particularly 46.7%. And as we basically progress from Child C through C, the prevalence increases. On the right side, the survival chart shows the cumulative survival rates at 1, 3, and 5 years for patients with and without sarcopenia. At 1 year, survival is 93.4% for non-sarcopenic patients compared to 76.6%. At 5 years is 74.2% in non-sarcopenic versus 45.3% for those without sarcopenia. And the hazard ratio is 2.3, indicates that sarcopenia is more than doubles the risk of mortality in cirrhotic patients. So in conclusion, sarcopenia is highly prevalent in cirrhotic patients, particularly those with alcoholic liver disease and advanced liver disease, and significantly reduces survival, highlighting the importance of addressing muscle loss in these patients. This slide illustrates the relationship between MEL score and the 3-month survival in patient cirrhosis, highlighting the window for nutritional assessment. On the x-axis, we have MEL score, which increases as liver function worsens. On the y-axis, we have the percentage of 3-month survival. As the MEL score increases, we see a sharp decline in survival, specifically once the score surpasses about 20. The blue shaded area represents the optimal window of nutritional assessment, which is when the MEL score is between 10 to 20, I'll say. This is a critical period where patients are still relatively stable, but at a significant risk of complications. So addressing malnutrition and sarcopenia during this window can help improve outcomes before survival chances drop steeply with higher MEL scores. So in summary, again, early and proactive nutritional intervention in cirrhotic patients, especially when their MEL score is between 10 to 20, can play a vital role in optimizing their survival. Now, this particular slide presents the data on the impact of sarcopenia on patients undergoing liver transplantations. Now, the top right box highlights the key findings. There is no significant difference in median survival after liver transplantation between sarcopenic and non-sarcopenic patients. Again, I just want to emphasize this is a single study, and we'll talk more about meta-analysis in the later on. But this particular study didn't find. But what this study highlights that the sarcopenic patients, they experience longer hospital stays, almost up to 40 days plus versus 25 days with a P of 0.005, indicating that sarcopenic individuals, there is an increased length of stay and increased post-operative complications as well. Sarcopenic patients have higher frequency of bacterial infections within the first 90 days after transplantations, again, almost 26% versus 15%. And Kaplan-Meier curve also shows on the left side, however, so there is no difference in the overall survival, but I can see some trend here, and maybe with a larger number of patients, this might change, and which we'll see then in subsequent slides. While the overall infection rate does not significantly differ, sarcopenic patients are more prone to, as I mentioned, bacterial infection, and even the other infections were not that different in this particular slide. Now, we're going to review a little bit about living donor liver transplantation in this slide, and what basically the study, which includes about 2,816 recipients who underwent living donor liver transplantation between 2008 and 2018 over a span of 10 years. The Kaplan-Meier survival curves illustrate the difference in outcomes between patients with and without sarcopenia. What we see here is 180-day graft failure. The green line represents patient sarcopenia, while the blue represents those without. And sarcopenic patients have significantly higher graft failure within 180 days. And overall graft failure is also kind of similar, significantly different. And survival on the lower side, you can see also is kind of similarly lower in sarcopenic individuals, quite significantly as compared to the non-sarcopenic individuals. And here we see a meta-analysis, which summarizes impact of sarcopenia on both pre and post-transplant outcomes. The meta-analysis include 19 studies. As you see here, sarcopenic, the prevalence of sarcopenia in these studies range from 22.2% to about 70%. And the sarcopenia significantly increases the risk of mortality for patients on their liver transplant wait list. And the pool hazard ratio is about 1.72, indicating the higher risk of death while waiting for a liver transplantation in sarcopenic patients. Now, the next focus here is post-transplant mortality. And sarcopenia also affects survival after liver transplantation. The pool hazard ratio is 1.84, indicating significant increase in post-transplant mortality in sarcopenic individuals. And finally, SMI and post-transplant mortality is also looked specifically. And here in this plot, it shows that a lower SMI is associated with higher mortality with a pool hazard ratio of 1.09. So in summary, sarcopenia is an independent risk factor for both wait list and post-transplant mortality. And these associations were observed independently of the MELD scores, which is the standard model for assessing liver disease-related severity. So in conclusion, sarcopenia is a significant predictor of poor outcomes in liver transplant candidates, both before and after the transplant. And these findings again highlight the importance of addressing muscle mass loss in managing cirrhotic individuals awaiting for liver transplantations. Now, this slide highlights the clinical significance of frailty in patients with cirrhosis and its impact on outcomes. So on the left side, we see a diagram showing how various complications of cirrhosis, including malnutrition, portal infections, sarcopenia, and impaired metabolism contributes to hepatic decompensations and reduced functional capacity and even cognitive dysfunction. So together, these lead to the development of frailty, which is a key factor that increases the risk of falls, fractures, and hospitalization, and ultimately results in limited recovery and repeated hospitalizations. On the right side, we have highlighted key points about how frailty is measured and its relevance. Now, the metrics of illness of severity of cirrhosis include MELD, which is currently the MELD 3.0 score, and more recently, the liver frailty index. Now, MELD 3.0 is used to prioritize allocation based on disease severity and life expectancy over a 3-month period. And the score includes, as we all know, creatinine, bilirubin, INR, albumin, sodium, and gender, and the need for dialysis. Now, MELD 3.0 score can range from 6 to 40, with a higher score indicating increased mortality risk. Importantly, frailty is not accounted in the MELD 3.0. But thankfully, albumin levels can reflect to some degree the malnutrition, which is a component of frailty. And I think as you have all seen, this MELD score has evolved over time. The initial MELD score went to MELD sodium and now MELD 3.0. We hope that the frailty will also be counted in the future significantly into this MELD score, as we all see so far that frailty significantly impacts the outcome in this individual, even in the low MELD score as well. Some adjustment is needed. Now, this slide compares the effectiveness of combining the liver frailty index and the MELD sodium score versus MELD sodium alone in predicting 3-month waitlist mortality in patients with cirrhosis awaiting liver transplantation. The graph on the left, which is an ROC curve, shows the solid line represents the combination of the liver frailty index and the MELD sodium, which is achieving a AUC of 0.79. And the dashed line represents the MELD sodium alone, which is an AUC of 0.73. So higher AUC per the combination indicates that adding liver frailty index improves accuracy of predicting the 3-month waitlist mortality compared to using MELD sodium alone. The graph on the right, which also looks into the cumulative incidence of the waitlist mortality. Now, this graph shows the cumulative incidence of waitlist mortality based on different combinations of liver frailty index and MELD sodium scores over time. Patients with both higher liver frailty indices like 4.7 and above and higher MELD sodium score more than 23 have the highest mortality risk, the top black line. In contrast, the patients with a low liver frailty index, 3.4, and lower MELD sodium score less than 14 have a significantly lower waitlist mortality. So this illustrates that both frailty and liver disease severity significantly influence waitlist outcomes, and their combination provides a more precise mortality risk assessment. So the key takeaway is that adding liver frailty index to MELD sodium improves the ability to predict mortality in cirrhotic patients awaiting liver transplantation, and this combined approach is better identifies those who are at higher risk of dying on waitlist. So how do we assess the tools that we have to measure sarcopenia and frailty? Now, this slide summarizes the various tools used to measure sarcopenia and frailty in clinical practice, divided into 3 main categories: the low muscle mass, reduced muscle function, and reduced muscle strength. Now, the tools listed here are used to assess muscle quantity or the size. Now, CT scan and MRI, both are gold standards for precise muscle mass measurement, especially around L3 vertebra level. Muscle ultrasound is a more accessible and less expensive method for assessing muscle mass and has not been used widely, but again, it's a good tool to assess muscle mass as well. I think more validation is definitely needed. And then the dual energy X-ray absorptiometry, or DEXA, this is used to measure body composition, including muscle mass. Now, mid-arm muscle circumference, which is a simple clinical measure of muscle mass and can be used as well. And then the bioimpedance analysis, which estimates the body composition, including muscle mass, by analyzing the electrical impedance through the body. Then reduced muscle function. This is the green section here. These tools assess muscle performance and overall functional capacity. Now, first is the SOT for physical performance battery test, the series of tests to evaluate balance, walking speed, and leg strength. And the liver frailty index, I will elaborate a little bit more because it is more widely used nowadays in many centers across the world, including our centers. It's a specialized tool they're designed to assess frailty in patients with the liver disease. Another simple test is the 6-minute walk distance. It measures the distance a patient can walk in 6 minutes and reflecting the overall endurance. And finally, cardiopulmonary exercise testing that assesses the heart and the lung capacity during physical activity, giving insights into the overall muscle function. Now, finally, the reduced muscle strength. And there are various tools. As we can see here, it's been highlighted. Number one is the hand grip strength, one of the simplest and most commonly used measure of muscle strength. You can just use a hand dynamometer to assess this. And then that's also part of the liver frailty index measurement. And then the stair climb power test. They measures the lower body muscle strength by timing how quickly a patient can climb stairs. And then finally, the time get up and go test that evaluates both strength and functional mobility by timing how quickly a patient can rise from a seated position and walk a short distance and return back to the sit down position. So in conclusion, together these tools provide a comprehensive assessment of muscle health from mass and strength to function. And accurate evaluation of sarcopenia and frailty helps guide intervention and improve outcomes, particularly in patients with chronic liver disease. Here is a table that gives an overview of the different methods to measure sarcopenia in patients with cirrhosis, including their advantages, disadvantages, and suggested cutoff points for diagnosing sarcopenia. I'm just putting it out, and the slide will be available on the online, so you can review more details. But there is all this study, all these different methods have some advantages and some disadvantages, and availability as well at various sites. So you can choose which one you want, depending on the availability of your sites. Now, this slide shows the added prognostic value of the hand grip strength in predicting survival in men with cirrhosis, compared to traditional imaging-based measures of muscle mass, such as CT and the DEXA scan. Now, transplant-free survival is reduced in patients with sarcopenia, which can be measured through various methods. And the Kaplan-Meier curves and the demonstrate survival based on the muscle mass and strength. So first, the panel A on the top, that one, the panel A, which is with the CT scan, the Kaplan-Meier curve shows the survival probability based on CT-derived muscle mass, and the patient with muscle mass less than 52.4, which is the green line, have a worse survival compared to those with higher muscle mass, which is the orange line. Again, you see the p-value 0.03 here. Now, this panel B, it is using the DEXA muscle mass. Now, this curve is again based on the DEXA muscle mass measurements, and what we saw here is a patient with a muscle mass less than 7.26 also shows reduced survival compared to those with higher muscle mass. Now, the panel C, which is what is a more important one that I want to highlight based on comparison of these two, is based on the hand grip strength. And again, you see a hand grip strength of less than 30, which is the green line, have a significant worse survival compared to those with a strong hand grip, which is the orange line illustrated in this one. So this indicates that hand grip strength provides a stronger prognostic value. And in fact, you see the p-value is much stronger there, indicates a better prognostic value. So key takeaways from here is that while imaging-based measures like muscle mass based on CT scan and DEXA are good tools to measure sarcopenia, a hand grip, which is simple test and easily available, is also a very powerful tool that could be routinely incorporated into clinical practice. Now, here, this slide highlights the additional prognostic value of hand grip strength compared to MELD score in predicting mortality and transplant outcomes in men with cirrhosis. Now, on the left panel, we have the CIC for hand grip strength. The solid line here represents the cumulative incidence of mortality based on hand grip strength. The blue lines represent the hand grip strength more than 30 have a lower risk of mortality, and black line presents the hand grip strength less than 30 have a higher mortality risk. So poor muscle strength have a higher mortality risk. Now, the dashed line, however, shows the incidence of transplant. Now, the blue dashed lines express patients with stronger hand grip strength are more likely to survive longer before needing a transplant. And the p-value again is 0.58, suggests no significant difference in transplant outcome based on hand grip strength alone, but mortality risk is still clinically relevant in these patients. On the right side, you have solid line representing mortality based on MEL scores. Again, blue line, MEL score with less than 17 have a better survival, and the MEL more than 17 have a higher mortality. And the dashed line show transplant outcomes. And it's just to show the comparison between how hand grip and this MEL score affects the survival in these individuals. So the key takeaway from this one is that the slide basically illustrates that hand grip strength may add significant prognostic value in assessing outcomes of liver transplant candidates, particularly for predicting mortality. While MEL score is a critical measure, combining its assessments with muscle function, such as hand grip strength, could provide a more comprehensive evaluation in cirrhotic individuals. So to get a grip on sarcopenia for the liver transplant candidate, it's time to focus on muscle function as well. Now, I want to highlight the liver frailty index. This is a tool used to assess frailty in patients with liver cirrhosis, in liver disease and cirrhosis, particularly those awaiting liver transplantation. Now, frailty was evaluated using 3 physical performance tests. Number 1, we talked about hand grip strength. This is incorporated into it. This test measures the grip strength using hand dynamometer. The mean of 3 trials in the patient's dominant hand is taken, and the result is recorded in kilograms. The balance test is measured by having the patient stand in 3 progressively more challenging positions, side to side, semi-tandem, and tandem. And each position is held for about 10 seconds, and the time is recorded. Now, finally, the chair stance. This test measures the time it takes for the patient to stand up from a seated position in a chair 5 times with their arms folded across their chest. And this evaluates lower body strength and endurance. So you are assessing the balance, you are assessing the strength of upper extremity and the strength of lower extremity. And all this included in this liver frailty index. And then it is put into a formula, which I'll show you in a second, and that and spits out a score. And the score, the cutoff levels has been validated in multiple studies. Robust is less than 3.2, pre-frail is 3.2 to 4.5, and a score more than 4.5 is at frail. So higher the scores, the frailer the patient is. And here, this is the formula that I would just mention to it, Jennifer Lai's contribution, and they have done wonderful works on this and numerous publications around with using this as well. And here, this slide actually, again, we already talked about it, but what I want to highlight here is that you can see the graph on the right side that shows the correlation between the liver frailty index and the mortality. And you can see clearly there is a linear progression, an exponential progression as the LFI increases and the risk of mortality. So the LFI allows clinicians to objectively assess frailty, an important predictor of adverse outcomes, and tailor patient care accordingly. So here again, just to summarize, the liver frailty index is predictive of waitlist mortality. It's an excellent inter-rater reliability. The index of more than 4.4 identifies patients who are frail at higher risk of 3-month waitlist mortality. And index of more than 4.2 identifies those with a greater than 6-month and 12-month waitlist mortality. Now, this slide shows how liver frailty index changes over 3-month period, that's the delta, in the different patient trajectory groups affects the outcomes. First, just to mentioned the group can be categorized as steep worsening, moderate worsening, stable, improved, and overall. So I will show you in the next slide how this delta affects the outcomes. Now, this slide shows the impact of the changes in the liver frailty index over 3 months on waitlist mortality for liver transplant candidates. So the graph on the right highlights the cumulative incidence of waitlist mortality for different groups. And what you see is this trajectory, which is drawn over a period of 24 months. Improved frailty, patients who show an improvement in their liver frailty status have the lowest waitlist mortality. The 6-month mortality is about 0.6%, 12 month is 1.2% in those individuals, and 24 months 7.3%. So improved liver frailty index have a lower mortality. Now, those who have stable frailty without improvement have a 35% mortality. And again, 35% to individuals I'm talking about here in this group. So patients who remain stable in their frailty status have a moderate mortality rates going from 7%, 10%, and 17.3%. Now, moderate worsening, again, so clearly you see a trend here, and with the severe worsening, there is a significant worsening in their mortality. So by identifying this delta, you can also categorize these patients in how likely this patient is going to do in the next 24 months, and we can tailor our interventions to improve their frailty in these individuals. This slide presents the table, a table showing how changes in baseline risks, including the delta liver frailty index, baseline liver frailty index, and MELD sodium scores predict mortality for liver transplant candidates. I think this is important just because you can see how these are compared, like even MELD sodium and delta LFI, how they compare in predicting these outcomes. And you can see here the delta LFI per 0.1 unit worsening every 3 months. On multivariate analysis, the odds is like 2.04, whereas the MELD sodium per each 5-unit increase is 1.11. So delta LFI is a much stronger predictor when there are worsening happening in predicting the mortality on multivariate analysis. So MELD predicts mortality. MELD increase also predicts mortality, and we can see that's also important. However, the delta LFI appears to be a much stronger predictor in predicting mortality in these individuals. Now, we want to look into the various components of cirrhotic individuals waiting in the wait list and how that affects and their mortality in relationship to frailty here. And this is looking at the impact of frailty on 12-month waitlist mortality in liver transplant candidates, comparing again frail and non-frail individuals. So what do we see here? No ascites and no hepatic encephalopathy. You can see frail patients have a 16% waitlist mortality compared to 9% in the non-frail patients. Now, no ascites, frail patients have 25% mortality rate versus 10%. Now, with ascites, 39% versus 16%. No hepatic encephalopathy, 23% versus 11%. With hepatic encephalopathy, 38% versus 16%. And both ascites and encephalopathy. So what we are trying to highlight, or the authors try to highlight on this, is that frailty is a significant predictor of higher mortality on the wait list, regardless of whether the patient has ascites or hepatic encephalopathy. Again, the p-value is about 0.02 across these comparisons, less than 0.02 across the comparison that demonstrate that difference between the frail and non-frail patients are statistically significant. So what we can summarize from all this that we discussed so far, that sarcopenia and frailty is a robust predictor of a wide spectrum of outcomes in adults with cirrhosis, both with and without hepatocellular carcinoma. These outcomes include mortality both before and after liver transplantation, hepatic decompensation, reduced quality of life, increased risk of infection, prolonged hospitalizations. I want to highlight this important study that was published in JAMA Surgery. the association between frailty, obesity, and liver transplant waitlist mortality that was explored across 1,108 liver transplant candidates. The general findings here, there are 290 patients in the study, 26.2% were categorized as frail. Among them, 64 of the 246 candidates with class 1 obesity, like 26%. Class 2 or greater was 29%. There was no significant difference in frailty prevalence by obesity class. Okay, so that the prevalence was not different. But the key observation is the non-obese frail candidate and the frail candidates with class 1 obesity had a higher risk of waitlist mortality compared to their non-frail counterparts. Non-obese candidates, hazard ratio 1.54. Class 1 obesity, hazard ratio 1.72. So non-obese, frail candidates, as well as frail candidates with class 1 obesity had higher risk of waitlist mortality. Now, frail candidates with class 2 or greater obesity has a much higher, 3.19 for higher risk of adjusted risk of waitlist mortality compared to non-frail candidates with class 2 or greater. So again, this is what the key message from this slide is that frailty significantly increases waitlist mortality, especially among candidates with class 2 or greater obesity, underscoring the compounded risk posed by both frailty and higher risk levels of obesity in liver transplant candidates. So I think, again, this is something, again, highlights sarcopenic obesity and its impact on these individuals. This is, again, just to highlight a summary. Recently, we published in Clinical Liver Disease a review, and then my fellow Alexa wrote this article. Just summarized all these findings here. The liver transplant waitlist mortality that is in pre-LT frailty and pre-LT sarcopenia, pre-liver transplant frailty and sarcopenia, how that has affected from the summarized from various studies. And you can see here increased mortality, decompensation, delisting, potential worsening of frailty, post-transplant, increased mortality, longer hospital stay, longer ICU stay, quality of life reduced, increased 90-day rehospitalization, higher non-home discharge, and potential worsening of frailty. And sarcopenia also similarly affects basically the study has been highlighted, affects all these parameters as well, and also not just increase the mortality or increase ACLF events, increase risk of decompensation after TIPS placement, associated risk of post-TIPS encephalopathy, and increased health-related cost for patients, and potential worsening of sarcopenia. And all these similar measures that we saw in frailty also been highlighted here. So now, does the treatment of sarcopenia and frailty work? Now here, the effects of prehabilitations on frailty and survival in advanced liver cirrhosis, liver disease is highlighted, published in the American Journal of Gastroenterology. Here, the study involved 517 end-stage liver disease patients. The median age was 61 with a BMI of 30, and 59% were male, and the median MELD score was 12. The frailty was assessed using liver frailty index, 6-minute walk test, and gait speed test. And the intervention was patients basically, first of all, were categorized into the, again, frail, pre-frail, and the robust, and the frail and pre-frail patient received individualized exercise prescription, and follow-up physical therapy visits were scheduled every 1 to 3 months with frailty assessments and self-reported adherence to exercise. And what they find was frailty was associated with decreased survival, with the non-frail patients having significantly better survival compared to frail individuals. Prehabilitations led to significant improvement in frailty scores, and liver frailty index improvement was linked to increased survival on univariate analysis, and compliance with physical therapy also was associated with improved survival, with a notable hazard ratio improvement for those who attended multiple visits, like at least 1 visit as a reference, and 2 visits and 3 visits led to better outcomes. So overall, prehabilitation intervention, especially with regular physical therapy follow-ups, significantly improved survival outcomes in frail end-stage liver disease patients in this study. I encourage you to review with more detail this particular study that was published in American Journal of Gastroenterology. Here, this image illustrates the reversibility of sarcopenia after liver transplantation using abdominal CT scans at L3 vertebral level. Now, the color key here, the red indicate the skeletal muscle, the green intermuscular adipose tissue, yellow the visceral adipose tissue, and the TL the subcutaneous adipose tissue. Now, what we're seeing here, the left image taken before the liver transplantation showing sarcopenia with a low skeletal muscle index about 44.5, and on the right image taken 20 months after liver transplantation, showing improvement of the SMI to 54.8, indicating reversal of sarcopenia post-transplantation. So this highlights that how muscle mass can recover after liver transplantation, emphasizing the dynamic nature of the sarcopenia and liver disease. So the improvement in skeletal muscle mass following liver transplantation is clinically significant in the context of patient recovery and long-term survival. So in a frail individuals going through transplantation, there is a very good potential for them to recover. But what if they don't recover? And this is what is highlighted here. So the non-resolution of sarcopenia after liver transplantation is associated with an inferior post-transplant survival. So this is key here. So this study actually looked at 1 year patient with resolved sarcopenia was 92% as the resolution of the sarcopenia, and unresolved was 77% here at 1 year. And 5 years, this is survival I'm talking about, okay? At 1 year, the survival is quite significantly different. And at 5 years, the survival was quite different when that non-resolution of sarcopenia has happened. All right, we've spoken up. Now let's focus a little bit on the therapeutic targets to treat sarcopenia in cirrhosis. Now, this diagram, again, going back to the original figure, kind of overlaps based on their pathophysiology, what interventions we can do. We talked about bacterial translocation, endotoxin release, and pro-inflammatory cytokines. So this, we can prevent and treat infections, optimize the management of cirrhosis complications to prevent muscle breakdown. Liver transplantation, as we saw, that can reverse the muscle mass and sarcopenia. So that is also an option of treatment, especially sarcopenic individuals. And we also mentioned that wait-list mortality significantly increases. So early transplantation, especially even in the male less than 15, and we mentioned these are patients who are not well served by the MEL scopes, could be saved and reverse the sarcopenia and a better outcome if they get transplanted. And we talked about hepatic urea cycle that are impaired, that is increased ammonia levels. There are no good studies I found that, of course, this has been shown that increased ammonia levels affects by stimulating myostatin and muscle breakdown, and reducing ammonia level could have a potential effect, beneficial effect. I didn't see any good study. Maybe this is what something you should look into it. Like someone, there is a role of measuring ammonia levels as an outpatient or keeping ammonia level at a certain extent. Will that help in the long term? I don't know the answer to that, but certainly it sounds like reducing ammonia level may have a better outcome in long-term outcome in this patient, or at least reducing their recurrent hospitalization with reducing the ammonia levels could potentially have a beneficial effect. Finally, starvation. Starvation, we talked about, like 6 to 8 hours of starvation is almost equivalent to 4 days of somebody, normal individuals of starvation. So they deplete their glycogen stores pretty quickly. So increase frequency of meals and also nighttime snacks, etc., to help preserve their glycogen store is very helpful in these individuals to decrease their muscle breakdown. Finally, branch chain amino acid supplementation. Again, this is also a key parameter, as we said. The branch chain amino acid, particularly leucine, has a role in muscle metabolism and improving muscles buildup. And so supplementing branch chain amino acids may potentially help in these patients. Of course, toxins, alcoholic patients, as we mentioned earlier, that alcoholics have the highest risk of having sarcopenia. And so stopping alcohol would definitely have a positive impact in these individuals. Now, intervention with physical activity, we'll talk a little bit more, but the essential is very important in these individuals. And again, these are some pathophysiological bases which can be targeted, like mitochondria, targeted antioxidants, and there are numerous trials going on around this. And testosterone, that could be a role on testosterone. And unfortunately, testosterone you can't use in females. And in male individuals with sarcopenia, who actually are the higher risk of having sarcopenia, you can check their testosterone level if there is low, and majority of these patients have hypogonadism and low testosterone level and could be supplemented with, of course, the safety and efficacy still needs to be established in these individuals, but certainly some trials have shown benefits, and I'll go over some of those trials as well. And here is a summarized management toolbox for addressing sarcopenia and frailty in patients with advanced liver disease, categorized into 4 key areas. Now, first is liver-specific management. So management of disease etiology, focusing on treating the underlying liver condition, such as viral hepatitis, alcoholic liver disease, or NASH, may potentially have beneficial effect in these individuals. Management of ascites, control of fluid accumulation in the abdomen. Recurrent TAP leads to a lot of loss of proteins, and they must always be supplemented with some albumin. And if we can control their ascites better, they, especially with maybe sometimes with tips, those with the refractory ascites may improve their sarcopenia as well. And there are some studies showing tips have a beneficial effect. And then management of hepatic encephalopathy, addressing cognitive dysfunctions caused by the liver failure is also significantly may help these individuals. Physical activity, the personalized activity prescriptions guided by the societies is very helpful, especially the FIT, which is called the frequency, intensity, time, and type. That's what the prescription should look like. The letters FITT. The frequency is aerobic exercise 4 to 7 days per week. Resistance training 2 to 3 days per week. The intensity, you can use the talk test to measure the appropriate intensity. Should be able to speak a full sentence without losing breath while doing their exercises, and perform 3 sets of 10 to 15 repetitions for resistance exercise. Then time. Time is start slow and then build up. Again, the aerobic 150 minutes per week, resistance more than 1 day per week, and the type of exercises should be mixed. Focus on aerobic, resistance, flexibility, and balance. We have to focus on all of those. And I think all this can only be done by a certified exercise physiologist or physical therapist who can focus specifically a special this FIT exercise. It should be a personalized activity prescription for individuals with cirrhosis. And actually in our center, we have a program which is we have multiple centers called STARS rehabilitation centers across in Long Island, where our center is located, and we work with at least 13 physical therapists who are trained to assess liver frailty index at their center and also follow up their improvement. And they do specific prescription for these individuals and follow them as an outpatient and to improve their liver frailty index. Finally, it's also important the intake, calorie intake. Again, at least 35 kilocalories per kg in non-obese individuals. And the protein intake is much higher. They should be getting 1.2 to 1.5 gram per kg body weight. And they all need micronutrient repletion, frequent, small meals, and minimize fasting. And we talked about it. Late evening snack pretty much helpful. And address any barriers of intake. For example, liberalized sodium restriction as needed. These are individuals, they have a low appetite. They're not going to eat much. And with a rigorous 2 gram salt restriction may not work in these individuals. You might increase your diuretics to control their ascites or other ways to measure. But if you keep that strong 2 gram salt restriction, it may not work in some of these patients because they're going to lose more muscle mass otherwise. And of course, you need to work with a registered dietitian to help individualize these treatment decisions. Finally, testosterone replacement therapy in men may be a benefit. And and then also referred to health behavior specialist. Many centers have included a health behavior specialist. So the next is the medications for the treatment of sarcopenia, which is this is the review where basically sarcopenia can be targeted by various drugs that has been summarized here: testosterone, selective androgen receptor modulators, estrogen, dihydroepiandrosterone, insulin-like growth factor 1, growth hormone, and many others we highlighted. So this has been tried, and it's not specifically in cirrhotic. I'm talking about as a measure of sarcopenia, especially in older age. This has all been tried. Whether that can be translated in cirrhotic individuals is a question. And then there are some studies have already done, and I'm going to highlight a little later about those. But there are so many clinical trials in sarcopenia. You can find the clinical trials curve in different phases. And these are not for cirrhotic patients. These are all for sarcopenic individuals. There have been numerous trials on this, and some of these are already like the LPC and 114 has already been tried in cirrhotic individuals as well, and studies are awaited. The results are awaited in this. And this is a study looking into testosterone supplements and its impact on sarcopenia and frailty in cirrhotic individuals. And what I would like to highlight here, this table discusses the testosterone supplements and their impact on sarcopenia and frailty in cirrhosis. But what the key findings is, there is, this is a busy, complicated slide, but key findings are it increases in muscle mass, testosterone supplements, and improves the muscle strength, particularly the hand grip strength that has been used in these various studies. So potentially, this testosterone will be helpful. But what is the adverse events? In all the studies that I have found that not much of a significant side effect they have described, except for some nipple tenderness in some of the studies, but no major adverse events. But so testosterone supplements potentially could be useful in these individuals. And here is one study I want to highlight, which summarizes the findings regarding serum testosterone levels and testosterone supplementation in cirrhosis. The studies link how low testosterone levels in cirrhotic patients leads to sarcopenia, shorter time to hepatic decompensation, transplant need, and the higher MEL scores and increased mortality in cirrhosis. And the interventional studies, there were 9 interventional studies involving 361 patients that treated with testosterone versus 219 placebo-treated patients. They follow up for like 1 to 36 months. They found improved serum testosterone levels, increased appendicular muscle mass, and improved bone mineral density. And these studies, they found the key limitations were, so despite improvement in muscle mass and bone outcomes, none of these studies reported improvement in liver-related outcomes, for example, liver-related scores, complications, readmission rates, or mortality. So the findings, although indicate that while testosterone supplementation may benefit muscle mass and bone health in cirrhotic individuals, its effect on liver-specific outcomes and survival remains uncertain. So finally, this is my summary. Our understanding of the pathophysiological mechanisms underlying sarcopenia and physical frailty and cirrhosis is continuously evolving. Sarcopenia has been linked to key factors such as cytokine release, endotoxemia, hyperammonemia, and low testosterone levels in males. Current management strategies are for sarcopenia and frailty in liver transplant candidates emphasize nutrition, adequate nutrition support, minimizing fasting periods, regular physical therapy, and optimized management of cirrhosis-related complications and an underlying cause. More work needs to be done in this area, although we all have clearly shown that sarcopenia, frailty affects waitlist mortality and the post-transplant outcomes. But the interventions are mostly focused around physical therapy and nutritional support. But drug therapy is an evolution, and we hopefully will find more strategies of improving these patients, and hopefully even these measures will be incorporated for prioritizing patients for liver transplantation as well. With that, I would like to thank you very much and for your attention, and I would be happy to take any questions. I'll share my screen.